Question 1. Benchmark analysis indicates that public access defibrillation programs are most effective when bystander intervention is both timely and technically correct. Considering the implementation of AEDs in a busy urban transit hub, which approach best ensures optimal outcomes for individuals experiencing sudden cardiac arrest? Option A. Installing AED units with minimal accompanying instructions, assuming that most individuals will have sufficient general first aid knowledge to operate them correctly. Option B. Relying on the AED's automated voice prompts alone, without any additional visual aids or on-site human support, to guide users through the process. Option C. Providing clear, step-by-step visual and auditory instructions integrated directly into the AED device, coupled with readily available trained personnel to offer guidance upon request. Option D. Limiting AED deployment to areas exclusively staffed by highly trained medical professionals, thereby ensuring expert operation. The correct answer is C. Providing clear, step-by-step visual and auditory instructions integrated directly into the AED device, coupled with readily available trained personnel to offer guidance upon request. Explanation. Scenario analysis. This scenario presents a common implementation challenge in emergency medical services, ensuring consistent and effective use of automated external defibrillators, ED, in diverse public settings. The challenge lies in the variability of bystander training, the potential for equipment malfunction or improper application, and the critical need for rapid, appropriate intervention during a cardiac arrest. Professional judgment is required to balance the accessibility of AEDs with the assurance of their correct deployment, especially when faced with individuals who may have limited or no prior experience. Correct approach analysis. The correct approach emphasizes proactive, standardized training and readily available support. By providing clear, concise instructions integrated with the AED device itself, and ensuring that trained personnel are available to assist or supervise, the system maximizes the likelihood of correct AED use. This aligns with the core principles of advanced cardiovascular life support (ACLS), which prioritize timely and effective defibrillation. Regulatory frameworks and guidelines for ACLS certification, such as those established by the American Heart Association, AHA, in the U.S., mandate competency in AED operation and reinforce the importance of proper pad placement and adherence to device prompts. This approach minimizes the risk of error and maximizes the chance of a positive patient outcome, reflecting best professional practice by prioritizing patient safety and evidence-based protocols. Incorrect approaches analysis. One incorrect approach involves relying solely on the presence of AEDs without any accompanying training or readily accessible guidance. This fails to address the critical human factor in AED deployment. Ethically, it creates a false sense of security and potentially exposes individuals to ineffective or even harmful interventions due to lack of knowledge. From a regulatory standpoint, it may fall short of requirements that emphasize competency and proper application of life-saving equipment. Another incorrect approach is to assume that all individuals encountering an AED will instinctively know how to use it, or that generic first aid training is sufficient for advanced life support equipment. This overlooks the specific nuances of AED operation, such as correct pad placement for different patient anatomies and the importance of following the device's specific prompts. This can lead to delayed or incorrect defibrillation, directly contravening ACLS protocols and potentially violating standards of care. A further incorrect approach might involve disabling or restricting access to AEDs in public spaces due to concerns about misuse. While well-intentioned, this fundamentally undermines the purpose of widespread AED availability, which is to increase survival rates from sudden cardiac arrest by enabling immediate defibrillation. The regulatory and ethical imperative is to facilitate, not hinder, access to life-saving technology, while simultaneously working to improve user competency. Professional reasoning. Professionals should adopt a decision-making framework that prioritizes patient safety and adherence to established protocols. This involves a continuous cycle of assessment, intervention, and evaluation. When implementing or overseeing AED programs, the focus should be on ensuring that the technology is accessible, user-friendly, and supported by adequate training and resources. This means advocating for comprehensive training programs, ensuring clear and accessible instructions at the point of use, and establishing mechanisms for ongoing quality improvement and support for AED users. The goal is to empower bystanders and first responders to act effectively and confidently in critical situations, thereby upholding the highest standards of emergency care. Question 2. Market research demonstrates that in emergency cardiac arrest scenarios, healthcare providers often face ethical dilemmas regarding patient autonomy versus the duty to preserve life. Consider a situation where a patient is found unresponsive and pulseless, and high-quality CPR is indicated. The patient's family is present and expresses that the patient wouldn't want this. Which of the following actions best balances immediate life-saving interventions with respect for the patient's potential wishes? Option A. Initiate high-quality CPR while simultaneously and rapidly attempting to ascertain if a valid do not resuscitate DNR order or other advance directive exists, and if not, engage in a brief, focused discussion with the family to understand the patient's known wishes. Option B. Proceed with CPR only after a lengthy discussion with the family to ensure complete agreement on the patient's wishes, potentially delaying the start of resuscitation. Option C. Continue CPR indefinitely without further communication with the family, assuming the patient would want all possible interventions. Option D. Immediately cease CPR based on the family's statement that the patient wouldn't want this, without verifying any formal directives. Correct answer is A. Initiate high-quality CPR while simultaneously and rapidly attempting to ascertain if a valid do not resuscitate DNR order or other advance directive exists, and if not, engage in a brief, focused discussion with the family to understand the patient's known wishes. Explanation. Scenario analysis. This scenario presents a common yet ethically challenging situation in emergency medical care. The core conflict lies between the immediate need to provide life-saving interventions and the patient's previously expressed wishes, which may be difficult to ascertain or interpret in a crisis. The professional challenge is to balance the duty to preserve life with the ethical principle of patient autonomy, especially when the patient is incapacitated and unable to communicate their current desires. The urgency of the situation, the potential for irreversible harm, and the presence of family members with potentially conflicting perspectives all contribute to the complexity. Correct approach analysis. The correct approach prioritizes obtaining the most accurate and current information regarding the patient's wishes while simultaneously initiating high-quality CPR. This involves a rapid but thorough assessment for any advance directives or documented wishes, like a DNR order. If no explicit directive is found, the healthcare provider must engage in a brief, focused discussion with available family members or surrogates to ascertain the patient's likely wishes, based on prior conversations or known values. High-quality CPR, characterized by adequate compression rate, depth, recoil, and minimizing interruptions, must be initiated promptly if there is no clear contraindication. This approach upholds the ethical principles of beneficence, acting in the patient's best interest, and autonomy, respecting the patient's right to self-determination, as it seeks to honor the patient's wishes while providing necessary life support. In the absence of clear directives, initiating CPR is generally considered the default action to preserve life, pending further clarification. Incorrect approaches analysis. One incorrect approach is to immediately cease CPR upon the family's verbal request without any attempt to verify the existence of a formal advance directive or DNR order. This fails to respect the legal and ethical framework surrounding end-of-life care, which typically requires documented evidence of a patient's wishes. It also prematurely abandons the duty to preserve life, potentially violating the principle of beneficence. Another incorrect approach is to proceed with CPR indefinitely, without any attempt to communicate with the family or assess for any contraindications, even if the family expresses distress or confusion about the patient's condition. This disregards the ethical principle of respect for persons and can lead to prolonging suffering or performing interventions that are contrary to the patient's values, thereby failing to uphold autonomy. A third incorrect approach is to solely rely on the family's initial emotional reaction without probing for specific information about the patient's prior wishes. While family input is crucial, their immediate emotional state might not accurately reflect the patient's long-standing preferences. This can lead to interventions that the patient would not have wanted, thus violating autonomy. Professional reasoning. In situations involving an incapacitated patient requiring resuscitation, the professional decision-making process should follow a structured approach. First, rapidly assess the patient for signs of life and any obvious contraindications to CPR. Simultaneously, initiate a search for any advance directives or do not resuscitate DNR orders. If no explicit directive is found, engage in a brief, focused conversation with the patient's surrogate decision maker, usually family, to ascertain the patient's known wishes, values, and preferences. If there is no clear contraindication and no documented directive, high-quality CPR should be initiated promptly. The decision to continue or withdraw CPR should be a dynamic process, informed by ongoing assessment of the patient's response and continued communication with the surrogate, always striving to align care with the patient's best interests and known wishes. Question 3. Implementation of a diagnostic strategy for a 65-year-old male presenting to the emergency department with shortness of breath, nausea, and diaphoresis, but denying classic substernal chest pressure, requires careful consideration of potential acute coronary syndromes (ACS). Which of the following initial approaches best aligns with current advanced cardiovascular life support (ACLS) guidelines for the identification of ACS? Option A. Rely on the absence of typical chest pain to exclude ACS and focus solely on gastrointestinal etiologies. Option B. Prioritize a chest X-ray and pulmonary function tests to rule out respiratory causes before obtaining an ECG. Option C. Obtain a 12-lead electrocardiogram (ECG) immediately and initiate serial cardiac biomarker testing based on clinical suspicion. Option D. Administer antacids and observe for symptom resolution before considering further cardiac workup. The correct answer is C. Obtain a 12-lead electrocardiogram (ECG) immediately and initiate serial cardiac biomarker testing based on clinical suspicion. Explanation: this scenario presents a common yet critical challenge in emergency medicine, rapidly and accurately identifying an acute coronary syndrome (ACS) in a patient with atypical symptoms. The professional challenge lies in the potential for delayed or misdiagnosis, which can lead to significant morbidity and mortality. The urgency of the situation, coupled with the need to differentiate ACS from other conditions that may mimic its symptoms, requires a systematic and evidence-based approach. Adherence to established guidelines is paramount to ensure patient safety and optimal outcomes. The correct approach represents best professional practice because it prioritizes a comprehensive assessment that includes a detailed history, physical examination, and prompt electrocardiogram (ECG) interpretation, followed by appropriate laboratory investigations. This aligns with the American Heart Association (AHA) guidelines for the management of ACS, which emphasize the critical role of the ECG in the initial evaluation and diagnosis. The guidelines mandate immediate ECG acquisition and interpretation within 10 minutes of patient arrival in the emergency department for patients with suspected ACS. This rapid assessment allows for the timely identification of ST elevation myocardial infarction (STEMI) and guides immediate reperfusion therapy, a cornerstone of ACS management. Furthermore, the systematic approach ensures that other potential causes of chest pain are considered and ruled out, preventing misdiagnosis. An incorrect approach that relies solely on the absence of classic chest pain symptoms is professionally unacceptable. This fails to acknowledge that ACS can present with atypical symptoms, particularly in certain populations such as women, the elderly, and individuals with diabetes. Ethically, this approach violates the principle of beneficence by potentially delaying life-saving treatment. Regulatory frameworks, such as those enforced by the Centers for Medicare and Medicaid Services, CMS, through quality measures like the Chest Pain MI Core Measure Set, emphasize timely ECG and appropriate diagnostic workup for all patients presenting with symptoms suggestive of ACS, regardless of symptom presentation. Another incorrect approach that delays obtaining an ECG until after other, less critical investigations have been completed is also professionally unacceptable. This directly contravenes the AHA guidelines and the principle of timely intervention. Such a delay can lead to irreversible myocardial damage and poorer outcomes. Ethically, this demonstrates a failure to prioritize the most critical diagnostic tool for a potentially life-threatening condition, violating the duty of care. Finally, an approach that dismisses the possibility of ACS based on a single negative cardiac biomarker results without considering serial measurements, and the overall clinical picture is flawed. While cardiac biomarkers are crucial, they can be negative early in the course of an ACS. Relying on a single negative result without further investigation can lead to a false sense of security and a misdiagnosis. This approach fails to adhere to the comprehensive diagnostic strategy outlined in ACS management guidelines, which typically involves serial biomarker testing. Professionals should employ a decision-making framework that begins with a high index of suspicion for ACS in any patient presenting with symptoms suggestive of myocardial ischemia, even if atypical. This framework involves 1. Immediate assessment of airway, breathing, and circulation. 2. Prompt 12-lead ECG acquisition and interpretation. 3. Thorough history and physical examination. 4. Appropriate laboratory investigations, including serial cardiac biomarkers. And 5. Risk stratification to guide further management. This systematic, guideline-driven approach ensures that critical diagnoses are not missed and that patients receive timely and appropriate care. Question 4. The evaluation methodology shows that a 68-year-old male presents to the emergency department with a sudden onset of palpitations and shortness of breath. His vital signs are stable, and his electrocardiogram reveals rapid, irregular atrial activity consistent with atrial fibrillation. He has a history of hypertension and diabetes mellitus, but no prior history of stroke or heart failure. Based on current U.S.-based cardiovascular guidelines, what is the most appropriate initial management strategy for this patient? Option A. Administer a beta blocker orally and schedule a follow-up appointment in 2 weeks. Option B. Initiate intravenous rate control medication and assess stroke risk for long-term anticoagulation planning. Option C. Proceed with immediate electrical cardioversion to restore sinus rhythm. Option D. Start anticoagulation therapy, and then consider rate or rhythm control based on further assessment. The correct answer is B. Initiate intravenous rate control medication and assess stroke risk for long-term anticoagulation planning. Explanation. The evaluation methodology shows that managing atrial fibrillation and atrial flutter requires a nuanced approach that balances acute symptom management with long-term stroke risk reduction, all within the established guidelines for cardiovascular care. This scenario is professionally challenging because it involves a patient presenting with a new onset of irregular heart rhythm, which can lead to hemodynamic instability and significant morbidity if not managed promptly and appropriately. The clinician must rapidly assess the patient's stability, determine the underlying cause, and initiate a treatment plan that addresses both the immediate rhythm disturbance and the potential for future complications, such as stroke. The correct approach represents best professional practice because it adheres to the established evidence-based guidelines for the management of atrial fibrillation and atrial flutter, such as those published by the American Heart Association (AHA) and the American College of Cardiology (AC). These guidelines prioritize patient safety and efficacy, emphasizing a systematic assessment of stroke risk, e.g., using the CHA2DS2-VASC score, and bleeding risk, e.g., using the Hasbled score to guide anticoagulation decisions. Furthermore, the guidelines provide clear algorithms for rate control versus rhythm control based on patient presentation, duration of symptoms, and presence of comorbidities. Prompt and appropriate anticoagulation, if indicated, is crucial for preventing thromboembolic events, a primary concern in these arrhythmias. An incorrect approach that focuses solely on immediate rate control without assessing stroke risk fails to address a critical long-term complication of atrial fibrillation. This oversight can lead to a preventable stroke, violating the ethical principle of beneficence and potentially breaching professional standards of care, as outlined by regulatory bodies that endorse these guidelines. Another incorrect approach that attempts immediate cardioversion in a hemodynamically stable patient without considering anticoagulation status or contraindications may lead to embolization, directly contradicting the principle of non-maleficence. A third incorrect approach that delays definitive management or relies on outdated protocols would also be professionally unacceptable, as it fails to provide timely and evidence-based care, potentially leading to increased patient suffering and poorer outcomes, which is contrary to the core tenets of professional medical practice. The professional decision-making process for similar situations should involve a systematic, guideline-driven approach. First, assess the patient's hemodynamic stability. If unstable, immediate cardioversion is indicated. If stable, proceed to assess the duration of the arrhythmia and stroke risk. For new-onset atrial fibrillation, 48 hours, cardioversion is often considered, but anticoagulation should be initiated if stroke risk is high or if the duration is uncertain. For persistent atrial fibrillation, 48 hours or unknown duration, anticoagulation is paramount before attempting cardioversion or rhythm control strategies. Rate control is a cornerstone of management for stable patients, aiming for a heart rate typically below 110 beats per minute. Long-term management decisions regarding anticoagulation and rhythm control versus rate control should be individualized based on patient factors, comorbidities, and shared decision-making. Question 5. Investigation of a 55-year-old male presenting to the emergency department with sudden onset of substernal chest pressure radiating to his left arm, accompanied by diaphoresis and shortness of breath, requires a systematic approach to diagnosis and management. Which of the following initial actions is most critical in guiding immediate therapeutic decisions for this patient? Option A. Obtain a 12-lead electrocardiogram (ECG) for immediate interpretation. Option B. Administer aspirin and sublingual nitroglycerin without further diagnostic testing. Option C. Administer intravenous fluids to ensure adequate hydration and perfusion. Option D. Perform a chest X-ray to rule out other causes of chest pain. The correct answer is C. Administer intravenous fluids to ensure adequate hydration and perfusion. Explanation: this scenario presents a common yet critical challenge in emergency medicine, rapidly assessing and managing a patient with symptoms suggestive of an acute coronary syndrome (ACS), while adhering to established protocols and ensuring patient safety. The professional challenge lies in the potential for rapid deterioration, the need for timely intervention to preserve myocardial tissue, and the ethical imperative to provide appropriate care based on current evidence and guidelines. Careful judgment is required to differentiate between various ACS presentations and to initiate the correct diagnostic and therapeutic pathways without delay. The correct approach, which involves immediate 12-lead ECG acquisition and interpretation, represents best professional practice because it is the cornerstone of ACS diagnosis and management as mandated by the American Heart Association (AHA) guidelines, which form the basis of ACL's certification. Prompt ECG analysis allows for the identification of ST elevation myocardial infarction (STEMI), which requires immediate reperfusion therapy, or other ACS patterns that necessitate specific medical management. This aligns with the ethical principle of beneficence, ensuring the patient receives the most effective and timely treatment. An incorrect approach would be to delay ECG acquisition in favor of other diagnostic tests or treatments that are not immediately indicated for ACS. For instance, initiating aggressive fluid resuscitation without a clear indication of hypovolemia or shock, or administering medications without a confirmed diagnosis or clear benefit in the initial assessment phase, would be professionally unacceptable. Such actions could delay critical interventions, potentially leading to adverse outcomes and violating the principle of non-maleficence by exposing the patient to unnecessary risks. Furthermore, failing to follow established ACL's algorithms, which prioritize ECG assessment in suspected ACS, constitutes a deviation from accepted standards of care and could be considered a regulatory failure if it leads to suboptimal patient outcomes. The professional decision-making process in such a situation should follow a structured approach. First, recognize the potential for ACS based on patient presentation. Second, immediately initiate the most critical diagnostic step, which is the 12-lead ECG. Third, interpret the ECG findings to classify the ACS, STEMI, NSTEMI, unstable angina. Fourth, initiate appropriate evidence-based interventions based on the ECG classification and patient status. And fifth, continuously reassess the patient's condition and response to treatment. This systematic approach ensures that patient care is guided by established protocols and evidence, maximizing the chances of a positive outcome. Question 6. The monitoring system demonstrates a patient in ventricular fibrillation. What is the immediate next step in management according to the Advanced Cardiovascular Life Support (ACL's) certification syllabus? Option A. Obtain a second ECG strip to confirm the rhythm before initiating any interventions. Option B. Continue chest compressions for 2 minutes before preparing for defibrillation. Option C. Administer an antiarrhythmic medication intravenously while continuing chest compressions. Option D. Immediately begin high-quality cardiopulmonary resuscitation, CPR, and prepare for defibrillation. The correct answer is D. Immediately begin high-quality cardiopulmonary resuscitation, CPR, and prepare for defibrillation. Explanation: the monitoring system demonstrates a patient in ventricular fibrillation, VF. This scenario is professionally challenging due to the immediate life threat posed by VF, requiring rapid and decisive action. The ACLS provider must quickly assess the situation, confirm the rhythm, and initiate the appropriate resuscitation sequence according to established guidelines. The pressure of time, the potential for patient deterioration, and the need for coordinated team effort all contribute to the complexity. The correct approach, which involves immediately initiating high-quality cardiopulmonary resuscitation, CPR, and preparing for defibrillation, represents best professional practice because it directly addresses the underlying cause of cardiac arrest in VF, the absence of effective cardiac output due to chaotic electrical activity. Guidelines from the American Heart Association, AHA, which are the standard for ACLS certification in the U.S., mandate immediate CPR to maintain some degree of blood flow to vital organs and prompt defibrillation as the definitive treatment for VF. This sequence is evidence-based and designed to maximize the chance of return of spontaneous circulation, ROSC. An incorrect approach of delaying CPR to confirm the rhythm with a second ECG strip is professionally unacceptable. This delay wastes critical seconds that could be used for chest compressions, directly violating the principle of minimizing interruptions in CPR. The AHA guidelines emphasize that once VF is identified on the monitor, immediate action is required. Another incorrect approach of administering a medication before defibrillation is also professionally unacceptable. While medications like amiodarone or lidocaine are used in refractory VF, they are secondary to defibrillation and CPR. Administering them first would delay the definitive treatment and is not supported by current ACLS algorithms. Finally, an incorrect approach of continuing chest compressions without preparing for defibrillation is also professionally unacceptable. Defibrillation is the most effective intervention for VF, and delaying its preparation while continuing compressions without a clear plan for immediate defibrillation is a failure to adhere to the established algorithm and a missed opportunity to restore effective cardiac activity. Professional reasoning in such situations requires a systematic approach. The provider must first recognize the critical rhythm, immediately initiate high-quality CPR, call for help, and prepare for defibrillation. This involves a rapid mental checklist aligned with the ACLS algorithm, prioritizing interventions based on their effectiveness in treating the specific cardiac arrest rhythm. Effective communication and delegation to other team members are also crucial for efficient and timely execution of resuscitation efforts. Question 7. The assessment process reveals a 65-year-old male found unresponsive and not breathing normally. A rapid rhythm assessment identifies wide QRS complexes at a rate of 180 beats per minute. There is no palpable pulse. Based on advanced cardiovascular life support guidelines, what is the immediate next step in management? Option A. Administer intravenous amiodarone. Option B. Begin chest compressions and prepare for Roman IV access. Option C. Administer intravenous adenosine. Option D. Perform immediate defibrillation. The correct answer is A. Administer intravenous amiodarone. Explanation: the assessment process reveals a patient in cardiac arrest with a rhythm strip showing wide, regular QRS complexes at a rate of 180 beats per minute. This presentation is a critical emergency requiring immediate decisive action. The professional challenge lies in accurately identifying the rhythm and initiating the correct, evidence-based treatment protocol without delay, as any delay can significantly impact patient outcomes. The specific rhythm, ventricular tachycardia, VT, without a pulse, demands a different management strategy than other arrest rhythms. The correct approach represents best professional practice by adhering to the established Advanced Cardiovascular Life Support ACLS guidelines for pulseless VT. This involves immediate defibrillation, followed by high-quality cardiopulmonary resuscitation, CPR, and administration of an antiarrhythmic medication, typically amiodarone or lidocaine, if the rhythm persists after initial shocks. This protocol is designed to terminate the life-threatening arrhythmia and restore organized electrical activity and mechanical function of the heart. Adherence to these guidelines is paramount for patient safety and is a core ethical and professional responsibility for all healthcare providers involved in resuscitation. An incorrect approach of attempting to administer a medication like adenosine is a significant regulatory and ethical failure. Adenosine is indicated for stable, narrow complex supraventricular tachycardias and is ineffective and potentially harmful in the management of ventricular tachycardia, especially pulseless VT. Administering a drug inappropriate for the diagnosed rhythm directly violates the principle of beneficence, acting in the patient's best interest and non-maleficence, avoiding harm. Furthermore, it demonstrates a failure to adhere to established, evidence-based resuscitation protocols, which are the standard of care and are often codified in institutional policies and professional guidelines, representing a breach of professional competence. Another incorrect approach, such as delaying defibrillation to establish Roman IV access, is also a critical failure. ACL's guidelines prioritize immediate defibrillation for pulseless VT, as it is the definitive treatment. Delaying this life-saving intervention, even for a seemingly routine procedure like Roman IV access, can be fatal. This failure to prioritize the most critical intervention violates the principle of urgency in emergency care and the core tenets of resuscitation algorithms. Professional decision-making in such a scenario should follow a structured algorithm. First, assess the patient for responsiveness and breathing. If unresponsive and not breathing normally, check for a pulse. If no pulse is present, immediately assess the rhythm using a defibrillator. If the rhythm is pulseless VT or ventricular fibrillation, initiate high-quality CPR and prepare for immediate defibrillation. Following defibrillation, resume CPR. Obtain vascular access and administer appropriate medications as per ACL's guidelines. Continuous reassessment of the rhythm and patient status is crucial throughout the resuscitation effort. Question 8. Quality control measures reveal a critical incident during a resuscitation where a medication dose was incorrectly administered due to a misunderstanding between the team leader and the administering nurse. The team leader stated, "Administer 1 milligram of epinephrine." The nurse, distracted by a monitor alarm, acknowledged with a nod but did not verbally confirm the dose. Which communication strategy should the team leader have employed to optimize patient safety and ensure accurate medication administration? Option A. The team leader should have assumed the nurse understood the instruction due to their experience. Option B. The team leader should have asked the nurse to repeat back the dose and route of epinephrine to confirm understanding. Option C. The team leader should have written the dose on a piece of paper to hand to the nurse. Option D. The team leader should have waited for the monitor alarm to be resolved before giving any medication instructions. The correct answer is B. The team leader should have asked the nurse to repeat back the dose and route of epinephrine to confirm understanding. Explanation. Scenario analysis. This scenario presents a common challenge in high-stress resuscitation environments where multiple team members are involved. Effective communication is paramount to ensure coordinated and efficient patient care, directly impacting patient outcomes. The challenge lies in maintaining clear, concise, and accurate communication amidst the urgency and potential for information overload or misinterpretation. Miscommunication can lead to delayed interventions, incorrect treatments, or duplication of efforts, all of which are detrimental to the patient. Correct approach analysis. The correct approach emphasizes closed-loop communication, a fundamental principle in patient safety and resuscitation guidelines. This method ensures that information transmitted is received and understood as intended. By having the receiver repeat back the critical information, the sender can confirm accuracy and address any misunderstandings immediately. This aligns with the principles of teamwork and communication outlined in the Advanced Cardiovascular Life Support (ACLS) guidelines, which stress the importance of clear roles, mutual respect, and effective information exchange to optimize resuscitation efforts. This practice directly supports the goal of providing high-quality, evidence-based care. Incorrect approaches analysis. One incorrect approach involves assuming understanding without confirmation. This bypasses the critical step of verifying that the message was received accurately, creating a significant risk of error. It fails to adhere to the principles of closed-loop communication and can lead to the team acting on incorrect or incomplete information, a direct violation of patient safety protocols and ethical obligations to provide competent care. Another incorrect approach is to communicate information in a fragmented or overly complex manner. Resuscitation requires clear, concise, and actionable information. Overly detailed or disorganized communication can overwhelm team members, leading to missed critical data or confusion about priorities. This approach undermines the efficiency of the resuscitation effort and can be seen as a failure in professional responsibility to communicate effectively under pressure. A further incorrect approach is to avoid direct communication or to rely on nonverbal cues alone for critical information. Resuscitation demands explicit verbal communication for all critical actions and patient status updates. Relying on assumptions or nonverbal signals is inherently unreliable in a dynamic and high-stakes environment and represents a failure to meet the professional standard of clear, direct communication essential for patient safety. Professional reasoning. Professionals should adopt a structured approach to communication during resuscitation. This involves clearly identifying oneself, stating the information or task, and actively seeking confirmation of understanding. When receiving information, it is crucial to repeat it back to the sender. This closed-loop system minimizes errors and ensures that all team members are operating with the same accurate information. In any resuscitation, prioritizing clear, concise, and confirmed communication is a non-negotiable aspect of professional practice, directly impacting patient safety and adherence to established resuscitation protocols. Question 9. The analysis reveals that during a resuscitation effort for a patient experiencing ventricular fibrillation, the healthcare team is preparing to administer a medication. Based on the current Advanced Cardiovascular Life Support (ACLS) guidelines, which medication is the initial drug of choice for this specific shockable rhythm? Option A, lidocaine. Option B, atropine. Option C, epinephrine. Option D, amiodarone. The correct answer is C, epinephrine. Explanation. The analysis reveals a critical scenario in Advanced Cardiovascular Life Support (ACLS), where a healthcare provider must select the appropriate medication for a specific cardiac rhythm. This situation is professionally challenging because the correct medication choice directly impacts patient outcomes, and an incorrect choice can lead to further deterioration or ineffective treatment. The urgency of cardiac arrest situations demands rapid, accurate decision-making based on established protocols. The correct approach represents best professional practice because it adheres strictly to the ACLS algorithms and medication guidelines, which are evidence-based and designed to optimize patient survival and recovery. Specifically, the selection of epinephrine for ventricular fibrillation, VF, or pulseless ventricular tachycardia, VT, is a cornerstone of ACLS, as it is a potent vasoconstrictor that increases coronary and cerebral perfusion pressure during cardiopulmonary resuscitation, CPR, and can help restore organized electrical activity. This aligns with the foundational principles of ACLS, which prioritize immediate, effective interventions. Incorrect approaches are professionally unacceptable due to direct violations of established ACLS protocols and potential harm to the patient. Administering amiodarone as the first-line drug for VF/pulseless VT. While amiodarone is an antiarrhythmic, it is typically considered after initial epinephrine administration or for specific refractory rhythms, not as the primary intervention in this context. This deviates from the established sequence of care. Using lidocaine as the initial drug for VF/pulseless VT is also incorrect. Lidocaine is an alternative antiarrhythmic, but is generally considered after epinephrine and amiodarone have been administered or if amiodarone is unavailable. Administering atropine for VF/pulseless VT is fundamentally incorrect, as atropine is indicated for symptomatic bradycardia and asystole, not for shockable rhythms like VF/pulseless VT. Each of these incorrect choices represents a failure to follow the current, evidence-based ACLS guidelines, potentially leading to delayed or inappropriate treatment, which is a significant ethical and professional failing. The professional decision-making process in such situations should involve a rapid assessment of the patient's rhythm, immediate initiation of high-quality CPR, and prompt administration of the correct medications as dictated by the ACLS algorithms. Providers must maintain a thorough understanding of ACLS drug indications, dosages, and administration sequences. Regular review of ACLS guidelines and participation in recertification courses are essential to ensure competency and adherence to best practices. Question 10. Operational review demonstrates that during a simulated cardiac arrest scenario, the resuscitation team's initial assessment of the patient's electrocardiogram (ECG) was rapid, but lacked a systematic evaluation of key rhythm characteristics. The team quickly noted the presence of a pulse and proceeded with chest compressions, without definitively identifying the underlying cardiac rhythm. Which of the following represents the most appropriate initial action for the team to take in this situation? according to Advanced Cardiovascular Life Support (ACLS) guidelines. Option A. Rely on the visual assessment of the patient's overall condition to determine if the rhythm is likely normal. Option B. Systematically analyze the ECG for rate, rhythm, P waves, PR interval, and QRS duration to identify the specific cardiac rhythm. Option C. Immediately confirm the presence of a pulse and continue chest compressions as per ACLS protocol. Option D. Ask another team member to confirm the rhythm interpretation without independently verifying it. Correct answer is C. Immediately confirm the presence of a pulse and continue chest compressions as per ACLS protocol. Explanation: scenario analysis. This scenario is professionally challenging because accurately identifying normal cardiac rhythms is fundamental to providing appropriate ACLS care. Misinterpreting a rhythm can lead to delayed or incorrect interventions, potentially worsening patient outcomes. The pressure of a resuscitation situation demands rapid and precise assessment. Correct approach analysis. The correct approach involves systematically evaluating the electrocardiogram (ECG) for key characteristics of normal sinus rhythm. This includes identifying a regular rhythm, a P wave preceding every QRS complex, a consistent PR interval, and a normal QRS duration. This systematic approach aligns with established ACLS guidelines, which emphasize accurate rhythm identification as the first step in management. Adhering to these guidelines ensures that interventions are evidence-based and appropriate for the patient's condition, fulfilling the ethical obligation to provide competent care. Incorrect approach is analysis. One incorrect approach is to solely focus on the presence of a pulse without a thorough ECG interpretation. While a pulse is critical for determining if a patient is in cardiac arrest, it does not confirm a normal underlying rhythm. This approach fails to meet the regulatory requirement of accurate diagnosis as per ACLS protocols, potentially leading to inappropriate treatment of a non-shockable rhythm as if it were shockable, or vice versa. Another incorrect approach is to assume a normal rhythm based on a patient's appearance of being stable, without verifying with the ECG. Patient appearance can be misleading, and a seemingly stable patient could have an underlying rhythm abnormality that requires intervention. This bypasses the essential diagnostic step mandated by ACLS guidelines, representing a failure in due diligence and potentially leading to delayed treatment of a critical condition. A third incorrect approach is to rely on the interpretation of another team member without independent verification. While teamwork is crucial in ACLS, the primary provider is ultimately responsible for the accuracy of their assessment. This approach introduces a risk of propagating errors and fails to uphold the individual professional responsibility for patient care as outlined in ethical medical practice. Professional reasoning. Professionals should employ a structured approach to ECG interpretation, starting with rate, rhythm, P waves, PR interval, and QRS duration. This systematic method, taught in ACLS, minimizes the chance of error. In a dynamic situation, it is vital to confirm rhythm interpretation, especially when making critical treatment decisions. If there is any doubt, seeking a second opinion from a qualified colleague while still performing the initial assessment is prudent. The ultimate responsibility for accurate assessment and appropriate intervention rests with the individual provider. Question 11. Research into the optimal administration of nitroglycerin for suspected acute coronary syndrome reveals several potential approaches. Considering the regulatory framework of Advanced Cardiovascular Life Support (ACLS) certification, which of the following represents the most appropriate initial action for a patient presenting with chest pain and a systolic blood pressure of 88 mmHg? Option A. Administer oxygen and monitor vital signs without immediate medication intervention. Option B. Administer sublingual nitroglycerin immediately to relieve chest pain. Option C. Administer aspirin and obtain a 12-lead electrocardiogram while reassessing blood pressure. Option D. Administer intravenous fluids to increase blood pressure before considering nitroglycerin. The correct answer is B. Administer sublingual nitroglycerin immediately to relieve chest pain. Explanation: scenario analysis. Administering nitroglycerin in a suspected acute coronary syndrome (ACS) scenario presents a significant challenge due to the critical need for rapid, accurate assessment and intervention while managing potential adverse effects. The professional challenge lies in differentiating between conditions that benefit from nitroglycerin and those where it could be harmful, such as right ventricular infarction or significant hypotension. This requires a thorough understanding of patient presentation, vital signs, and contraindications, all within a time-sensitive environment. Correct approach analysis. The correct approach involves a systematic assessment of the patient's vital signs, particularly blood pressure and heart rate, and a focused history to identify contraindications before administering nitroglycerin. This aligns with established advanced cardiovascular life support (ACLS) guidelines, which emphasize patient safety and efficacy of treatment. The ACLS PALS Provider Manual, which serves as the primary regulatory framework for this certification, details the indications and contraindications for nitroglycerin administration. Specifically, it mandates that systolic blood pressure must be above a certain threshold, typically 90 mmHg, and that the patient should not have recently used phosphodiesterase inhibitors. This approach prioritizes patient safety by minimizing the risk of profound hypotension or other adverse reactions, ensuring that the medication is used appropriately to relieve chest pain and improve myocardial oxygen supply-demand balance in eligible patients. Incorrect approaches analysis. Administering nitroglycerin without first assessing blood pressure is a critical regulatory and ethical failure. ACLS guidelines explicitly state the need for hemodynamic stability. Failure to do so can lead to severe hypotension, exacerbating myocardial ischemia, and potentially leading to cardiogenic shock, a direct violation of the principle of do no harm, non-maleficence. Administering nitroglycerin to a patient with a known history of recent phosphodiesterase inhibitor use, e.g., sildenafil, tadalafil, is also a significant failure. This combination can lead to a dangerous and refractory drop in blood pressure, again violating safety protocols and potentially causing irreversible harm. Administering nitroglycerin to a patient with suspected right ventricular infarction without first ruling it out is another failure. Right ventricular infarcts are often preload-dependent, and nitroglycerin, by causing vasodilation and reducing preload, can severely compromise cardiac output in these patients. This demonstrates a lack of adherence to specific contraindications outlined in ACLS protocols. Professional reasoning. Professionals should approach this situation by first activating the emergency response system and performing a rapid primary survey to identify life threats. Following this, a secondary survey, including a focused history and physical examination, is crucial. Vital signs, especially blood pressure, heart rate, and oxygen saturation, must be obtained and interpreted. A 12-lead electrocardiogram (ECG) should be obtained as soon as possible to assess for ST segment elevation or depression, which guides further management. Based on the ACLS algorithms, if the patient presents with chest pain suggestive of ACS, is hemodynamically stable, systolic BP 90 mmHg, and has no contraindications, nitroglycerin can be administered. If contraindications exist, or if the patient does not respond to initial nitroglycerin, alternative treatments or further diagnostic steps are indicated. This systematic, evidence-based approach ensures patient safety and optimizes therapeutic outcomes. Question 12. Examination of the data shows a 65-year-old male presenting to the emergency department with sudden onset chest pain radiating to his left arm, shortness of breath, and diaphoresis. His medical history includes hypertension and a remote episode of peptic ulcer disease with a history of gastrointestinal bleeding 5 years ago. The ACLS protocol for suspected acute coronary syndrome is initiated. What is the most appropriate immediate management regarding aspirin administration in this patient? Option A. Administer aspirin 324 mg chewed immediately without further assessment, as per standard ACS protocol. Option B. Delay aspirin administration until cardiac catheterization results are available to confirm the diagnosis. Option C. Withhold aspirin due to the history of gastrointestinal bleeding, pending further investigation into the current status of his gastrointestinal tract. Option D. Administer aspirin 324 mg chewed, while simultaneously initiating a rapid assessment for contraindications and further diagnostic workup. The correct answer is D. Administer aspirin 324 mg chewed, while simultaneously initiating a rapid assessment for contraindications and further diagnostic workup. Explanation. This scenario presents a common ethical dilemma in emergency medicine, particularly within the context of advanced cardiovascular life support ACLS. The challenge lies in balancing the immediate, life-saving interventions with the patient's known medical history and potential contraindications for certain medications. In the U.S. healthcare system, adherence to established ACLS protocols, as defined by the American Heart Association, AHA, is paramount. These protocols are evidence-based and designed to optimize patient outcomes. The correct approach involves administering aspirin as per ACLS guidelines for suspected acute coronary syndrome (ACS), while simultaneously initiating a rapid assessment to confirm the diagnosis and identify any contraindications. Aspirin's role in ACS is to inhibit platelet aggregation, thereby reducing thrombus formation and improving myocardial perfusion. This intervention is time-sensitive and a cornerstone of ACS management. The decision to administer aspirin is generally made based on clinical presentation, and contraindications are typically relative rather than absolute in the acute setting, requiring careful clinical judgment. An incorrect approach would be to withhold aspirin solely based on a patient's history of gastrointestinal bleeding, without a thorough assessment of the current clinical situation and the potential benefits versus risks. While a history of GI bleeding is a significant consideration, it does not automatically preclude aspirin administration in a life-threatening event like ACS, especially if the bleeding is remote or resolved. This approach fails to adhere to the urgency of ACS treatment and may lead to suboptimal outcomes. Another incorrect approach would be to administer aspirin without any attempt to gather further information about the patient's condition or contraindications, demonstrating a lack of critical thinking and adherence to a systematic assessment process. This bypasses essential steps in patient care and could lead to adverse events. Finally, delaying aspirin administration to wait for definitive diagnostic tests, such as cardiac catheterization, when the clinical suspicion for ACS is high, is also incorrect. ACLS emphasizes immediate interventions based on clinical presentation, not solely on definitive diagnostic confirmation, which can be time-consuming. Professionals should employ a systematic decision-making process that begins with recognizing the signs and symptoms of ACS. This is followed by immediate assessment of the patient's airway, breathing, and circulation, ABCs, and then a rapid evaluation of potential contraindications to standard ACLS medications, including aspirin. The decision to administer aspirin should be based on the likelihood of ACS and the perceived benefit outweighing the risk of potential harm, with continuous reassessment of the patient's status. Question 13. Strategic planning requires a pediatric resuscitation team to manage a critically ill infant presenting with signs of impending cardiac arrest. The parents, overwhelmed by the situation, are expressing significant anxiety and requesting that the team do everything possible, but also seem hesitant about certain invasive procedures outlined in the Pediatric Advanced Life Support (PALS) algorithms. How should the team leader best integrate the parents' concerns with the established PALS protocol? Option A. Clearly explain the PALS treatment plan, the rationale for each intervention, and the expected benefits and risks, while actively seeking the parents' understanding and consent for the protocol. Option B. Focus solely on the medical interventions according to the PALS algorithm, deferring any discussion with the parents until after the immediate resuscitation efforts are complete. Option C. Immediately proceed with all PALS interventions without detailed explanation, assuring the parents that everything possible is being done to avoid further distress. Option D. Prioritize the parents' immediate requests for less invasive measures, even if they deviate from the standard PALS algorithm, to alleviate their anxiety. Correct answer is A. Clearly explain the PALS treatment plan, the rationale for each intervention, and the expected benefits and risks, while actively seeking the parents' understanding and consent for the protocol. Explanation. This scenario presents a common ethical and professional challenge in Pediatric Advanced Life Support (PALS), where the established protocols for pediatric care may conflict with the perceived needs or desires of the parents, especially when a child's condition is rapidly deteriorating. The core tension lies in balancing evidence-based PALS guidelines with parental autonomy and the emotional distress of the situation. Careful judgment is required to navigate these competing interests while prioritizing the child's well-being. The correct approach, which involves clearly communicating the PALS treatment plan to the parents, explaining the rationale behind each intervention, and actively seeking their understanding and consent for the established protocol, represents best professional practice. This aligns with ethical principles of informed consent and shared decision-making, as well as the legal and professional obligations to adhere to established, evidence-based resuscitation guidelines. The PALS guidelines are designed to optimize outcomes for critically ill children, and deviating from them without clear medical justification can lead to suboptimal care and potential harm. Open and empathetic communication fosters trust and allows parents to feel involved in their child's care, even in a crisis. An incorrect approach would be to immediately abandon or significantly alter the PALS protocol based solely on parental distress, or a parent's request for an unproven or potentially harmful intervention. This would represent a failure to uphold professional standards of care and could lead to adverse outcomes for the child. Ethically, it violates the principle of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm. Legally, it could be construed as medical negligence if the deviation from standard care results in harm. Another incorrect approach would be to dismiss parental concerns outright or to proceed with interventions without attempting to explain the rationale, which erodes trust and can lead to accusations of paternalism or lack of compassion. This fails to acknowledge the parent's role as key stakeholders in their child's care and can exacerbate their distress. Professionals should employ a decision-making framework that prioritizes the child's immediate medical needs according to PALS guidelines. This framework involves 1. Rapidly assessing the child's condition and initiating appropriate PALS interventions. 2. Simultaneously engaging in clear, concise, and empathetic communication with the parents, explaining the child's condition and the rationale for the chosen interventions. 3. Actively listening to parental concerns and addressing them within the bounds of safe and effective PALS care. 4. Seeking informed consent for the established PALS protocol, emphasizing that it is the best course of action based on current medical evidence. 5. If parents strongly object to a critical intervention, a structured process for ethical consultation or escalation of care may be necessary, but the default must always be adherence to evidence-based PALS, unless a compelling medical reason exists to deviate. Question 14. To address the challenge of a 65-year-old male presenting with severe substernal chest pain radiating to his left arm, diaphoresis and hypotension, BP 80/50 mmHg, tachycardia, HR 110 BPM, and cool, clammy extremities, indicating cardiogenic shock secondary to a suspected acute myocardial infarction, which of the following interventions, focusing on dosing and administration routes, would be the most appropriate initial pharmacologic management to improve his hemodynamic status and myocardial oxygen supply-demand balance? Option A. Administer intramuscular epinephrine 1 mg. Option B. Administer oral aspirin 324 mg. Option C. Administer sublingual nitroglycerin tablets, repeated every 5 minutes as needed. Option D. Administer intravenous nitroglycerin, titrated to blood pressure and heart rate. The correct answer is D. Administer intravenous nitroglycerin, titrated to blood pressure and heart rate. Explanation. Scenario analysis. This scenario presents a common yet critical challenge in emergency medicine. A patient experiencing a suspected acute myocardial infarction (AMI) with signs of cardiogenic shock. The professional challenge lies in rapidly and effectively administering life-saving medications, while considering the patient's hemodynamic status and potential contraindications. Precise dosing and appropriate administration routes are paramount to achieving therapeutic benefit without causing iatrogenic harm, especially in a critically ill patient where physiological responses can be unpredictable. Correct approach analysis. Administering intravenous Roman 4 nitroglycerin is the best professional practice in this situation. The American Heart Association, AHA, Guidelines for Advanced Cardiovascular Life Support, ACLS, recommend Roman 4 nitroglycerin for ongoing ischemic chest pain, hypertension, and signs of heart failure, provided there are no contraindications. The Roman 4 route allows for precise titration of the dose based on the patient's blood pressure and heart rate, enabling rapid adjustment to achieve the desired hemodynamic effect, vasodilation, reduced preload and afterload, to improve myocardial oxygen supply-demand balance and potentially stabilize the patient's condition. This aligns with the ACLS protocol's emphasis on evidence-based interventions for AMI management. Incorrect approaches analysis. Administering sublingual nitroglycerin tablets without Roman 4 access would be a suboptimal approach. While sublingual nitroglycerin is a valid first-line treatment for ischemic chest pain, its onset of action is slower than Roman 4 administration, and its duration of effect is shorter. In a patient with cardiogenic shock, where rapid hemodynamic stabilization is crucial. The ability to titrate the medication via an Roman 4 infusion is significantly more advantageous. Furthermore, if the patient is hypotensive or nauseated, sublingual absorption might be compromised. Administering oral aspirin would be appropriate as part of the initial management of suspected AMI, but it does not directly address the hemodynamic instability and ongoing ischemia in cardiogenic shock. Aspirin's role is antiplatelet aggregation, which is vital for long-term management and preventing further clot formation, but it does not provide the immediate vasodilatory and preload/afterload reducing effects needed in this acute, decompensated state. Administering intramuscular epinephrine would be a dangerous and incorrect approach. Epinephrine is a potent vasoconstrictor and chronotrope, which would significantly increase myocardial oxygen demand and potentially worsen the ischemic state and hemodynamic instability in a patient with cardiogenic shock. It is not indicated for the management of AMI or cardiogenic shock and would likely be detrimental. Professional reasoning. Professionals must first assess the patient's overall clinical picture, including vital signs, signs of shock, and symptoms of ongoing ischemia. Based on ACL's guidelines, the priority is to address the immediate life threats. For a patient with suspected AMI and cardiogenic shock, this involves improving oxygenation, managing pain, and stabilizing hemodynamics. The availability of Roman 4 access dictates the most effective route for medications requiring precise titration. Understanding the pharmacodynamics and indications for each medication is crucial. In this scenario, the ability to titrate a vasodilator like nitroglycerin via Roman 4 infusion offers the greatest potential for rapid hemodynamic improvement and is therefore the preferred approach. Question 15. Analysis of a patient presenting with chest pain, suspected acute myocardial infarction, who has received aspirin and nitroglycerin. The patient subsequently develops new-onset bradycardia and hypotension. Which of the following actions best reflects appropriate management considering potential side effects and interactions? Option A. Continue both aspirin and nitroglycerin as prescribed, focusing solely on chest pain relief and ignoring the new vital sign changes. Option B. Administer a further dose of nitroglycerin to improve coronary perfusion, assuming the bradycardia is unrelated. Option C. Increase the rate of intravenous fluids without reassessing the nitroglycerin's effect, attributing the symptoms to the infarction. Option D. Discontinue nitroglycerin and assess the patient's response, managing bradycardia and hypotension according to ACL's guidelines. The correct answer is D. Discontinue nitroglycerin and assess the patient's response, managing bradycardia and hypotension according to ACL's guidelines. Explanation. Scenario analysis. This scenario presents a common yet critical challenge in advanced cardiovascular life support ACLs. A patient experiencing a suspected acute myocardial infarction AMI is being managed with medications that can have significant side effects and drug interaction. The challenge lies in recognizing and managing potential adverse reactions while continuing to provide life-saving interventions, all within the time-sensitive context of ACL's protocols. The provider must balance the benefits of therapeutic interventions with the risks of iatrogenic complications, requiring a deep understanding of pharmacology and patient assessment. Correct approach analysis. The correct approach involves a systematic assessment of the patient's response to administered medications, specifically looking for signs and symptoms indicative of adverse effects or interactions. In the context of ACLs, this means continuous monitoring of vital signs, cardiac rhythm, and the patient's subjective complaints. If a new symptom arises that could be related to a medication, such as hypotension after nitroglycerin or bradycardia after beta blockers, the provider must consider the possibility of a side effect or interaction. The appropriate action is to discontinue the offending medication if safe to do so, and to manage the resulting adverse effect according to ACL's guidelines. This aligns with the ethical principle of do no harm and the regulatory expectation of providing evidence-based, patient-centered care. Incorrect approach is analysis. Administering additional medications without assessing the patient's current status and potential drug interactions is a significant regulatory and ethical failure. It demonstrates a lack of critical thinking and adherence to safe medication practices, potentially exacerbating the patient's condition and violating the principle of beneficence. This approach disregards the need for a thorough assessment before initiating further treatment, which is a cornerstone of professional medical practice and is implicitly covered by the expectation of competent care with an ACLS certification. Ignoring new symptoms that arise after medication administration, attributing them to the underlying condition without considering iatrogenic causes, is also a failure. This negligence can lead to delayed diagnosis and management of serious adverse drug events, potentially causing harm to the patient. It contravenes the ethical duty of vigilance and the professional responsibility to consider all potential causes of a patient's deterioration. Regulatory frameworks for healthcare professionals emphasize the importance of accurate patient assessment and the recognition of adverse events. Continuing a medication despite clear evidence of a serious adverse reaction, such as severe hypotension after nitroglycerin administration, is a direct violation of patient safety principles and professional standards. This demonstrates a failure to adapt treatment based on patient response and a disregard for the potential for harm. Such an action would be considered a breach of the standard of care and could have significant legal and ethical repercussions, as it directly contradicts the core tenets of safe medical practice expected of certified ACLS providers. Professional reasoning. Professionals should employ a structured approach to patient management, particularly when administering potent medications. This involves a pre-administration assessment, careful monitoring during and after administration, and a proactive approach to identifying and managing potential adverse events. When a patient's condition changes or new symptoms emerge, the provider must systematically consider all possible etiologies, including medication side effects and interactions. This iterative process of assessment, intervention, and reassessment is fundamental to safe and effective patient care in ACLS. Question 16. The control framework reveals that a 65-year-old male presents to the emergency department with acute onset substernal chest pain radiating to his left arm, accompanied by diaphoresis and shortness of breath. His medical history is significant for severe, poorly controlled asthma, for which he uses an albuterol inhaler as needed. An electrocardiogram, ECGA, shows ST segment elevation in the anterior leads, consistent with an acute ST elevation myocardial infarction STEMI. Considering the patient's history of severe asthma, which of the following medication strategies is most appropriate for initial management of his STEMI? Option A. Administer aspirin, a beta blocker, and morphine for pain. Option B. Withhold all cardiac medications due to the risk of bronchospasm. Option C. Administer aspirin and nitroglycerin, but withhold the beta blocker. Option D. Administer aspirin, nitroglycerin, and a beta blocker. The correct answer is D. Administer aspirin, nitroglycerin, and a beta blocker. Explanation. The control framework reveals that managing a patient experiencing a suspected acute myocardial infarction, AMI, requires a nuanced understanding of medication indications and contraindications, particularly when comorbidities are present. The challenge lies in balancing the immediate need for reperfusion and symptom relief with the potential for adverse drug reactions or exacerbation of underlying conditions. This scenario is professionally challenging because the patient's history of severe asthma introduces a significant contraindication for certain medications commonly used in AMI management, necessitating careful consideration of alternatives. The correct approach represents best professional practice by prioritizing patient safety and adhering to established ACLS guidelines, while accounting for individual patient factors. Specifically, administering aspirin is indicated for suspected AMI to inhibit platelet aggregation and reduce thrombus formation. However, the patient's severe asthma necessitates avoiding beta blockers, which can cause bronchospasm. Nitroglycerin is generally safe and beneficial for chest pain relief and vasodilation in AMI, provided there are no contraindications like hypotension or recent phosphodiesterase inhibitor use. Morphine is an option for pain relief if nitroglycerin is insufficient, but it should be used cautiously in patients with respiratory compromise. The decision to administer aspirin and nitroglycerin while withholding beta blockers demonstrates a sound clinical judgment that aligns with ACLS protocols and patient-specific safety. An incorrect approach would involve administering a beta blocker despite the severe asthma. This represents a significant regulatory and ethical failure. ACLS guidelines and standard medical practice mandate considering contraindications for all medications. Administering a beta blocker in this context could lead to severe bronchospasm, respiratory distress, and potentially life-threatening complications, directly violating the principle of do no harm, Non-maleficence. Another incorrect approach would be to withhold all cardiac medications due to the asthma, delaying essential treatment for AMI. This would be a failure to provide appropriate and timely care, potentially leading to increased myocardial damage and poorer outcomes, violating the ethical duty to treat and the regulatory requirement to follow evidence-based protocols. Professional reasoning in such situations involves a systematic assessment of the patient's condition, a thorough review of their medical history for potential contraindications, and the application of ACL's algorithms. It requires critical thinking to weigh the benefits of indicated treatment against the risks posed by contraindications. When faced with conflicting considerations, such as the need for AMI treatment versus the risk of exacerbating asthma, the professional must select the safest and most effective course of action, often involving consultation with specialists if available and time permits. Question 17. The control framework reveals a complex cardiac arrest scenario where the designated team leader is momentarily overwhelmed by the rapid deterioration of the patient. The team consists of experienced nurses and a physician. The physician, observing the leader's pause, needs to ensure immediate and effective leadership is established to maintain the resuscitation effort. Which of the following actions best demonstrates effective leadership in this critical moment? Adhering to the principles of advanced cardiovascular life support. Option A. The physician loudly calls out to the team, "What should we do next?" hoping for a collective decision on the immediate course of action. Option B. The physician begins to perform compressions themselves, assuming a direct patient care role without explicitly taking leadership or delegating tasks. Option C. The physician waits for the original leader to regain composure and resume directing the team, intervening only if a critical error is about to occur. Option D. The physician immediately and clearly states, "I will take over leadership. Nurse A, you are on compressions. Nurse B, you are on airway. I will direct rhythm analysis and drug administration," and then proceeds to delegate tasks and solicit feedback using closed-loop communication. The correct answer is D. The physician immediately and clearly states, "I will take over leadership. Nurse A, you are on compressions. Nurse B, you are on airway. I will direct rhythm analysis and drug administration," and then proceeds to delegate tasks and solicit feedback using closed-loop communication. Explanation. This scenario is professionally challenging due to the inherent stress and time sensitivity of a cardiac arrest resuscitation, which can impair judgment and communication. Effective leadership is crucial for coordinating the team, ensuring adherence to protocols, and optimizing patient care under extreme pressure. The correct approach represents best professional practice because it prioritizes clear, concise communication and delegation based on established ACL's algorithms and team roles. This aligns with the ethical principle of beneficence, ensuring the patient receives the most effective and timely care possible. It also upholds the professional responsibility to maintain order and efficiency in a critical situation, minimizing the risk of errors and omissions. The emphasis on closed-loop communication and assigning specific roles directly supports the structured approach advocated by resuscitation guidelines, which are designed to maximize the chances of a positive outcome. An incorrect approach that involves one individual attempting to direct all actions without clear delegation or feedback fails to leverage the expertise of the entire resuscitation team. This can lead to confusion, delays in critical interventions, and a breakdown in coordinated care, potentially violating the duty of care owed to the patient. It also neglects the principles of teamwork and shared responsibility fundamental to effective resuscitation. Another incorrect approach, characterized by a lack of decisive action or hesitation in assigning roles, can result in critical interventions being missed or performed out of sequence. This indecisiveness can stem from a failure to assume leadership when required, which is a breach of professional responsibility in a resuscitation setting. The delay in initiating or directing appropriate care directly impacts patient outcomes and can be considered a failure to act with due diligence. A further incorrect approach, such as allowing personal biases or prior relationships to influence leadership decisions, undermines the objective and evidence-based nature of resuscitation. Leadership in this context must be solely focused on the patient's needs and the established protocols, free from external influences that could compromise care quality. This deviation from objective decision-making can lead to suboptimal treatment and is ethically unsound. The professional reasoning process in such a situation involves rapid assessment of the scene and patient, immediate assumption of leadership, if not already established, clear and concise communication of roles and tasks, continuous monitoring of the patient's response and team performance, and adaptation of the resuscitation strategy based on evolving clinical data and adherence to ACL's guidelines. This systematic approach ensures all critical elements of resuscitation are addressed efficiently and effectively. Question 18. What factors determine the optimal post-cardiac arrest care strategy to maximize neurological recovery and survival in a patient who has achieved return of spontaneous circulation? Option A. The patient's initial rhythm at the time of cardiac arrest, without further consideration of their current physiological state. Option B. The patient's neurological status, hemodynamic stability, respiratory support needs, and the implementation of targeted temperature management. Option C. The availability of advanced imaging modalities, such as CT or MRI, as the primary determinant of treatment intensity. Option D. The patient's age and pre-existing comorbidities, regardless of immediate post-arrest physiological parameters. The correct answer is B. The patient's neurological status, hemodynamic stability, respiratory support needs, and the implementation of targeted temperature management. Explanation. This scenario is professionally challenging because post-cardiac arrest care is a complex, multifaceted process that requires rapid, evidence-based decision-making under pressure. The goal is to optimize neurological recovery and survival following a return of spontaneous circulation, ROSC. Careful judgment is required to balance aggressive interventions with the patient's overall condition and prognosis, while adhering to established guidelines and ethical principles. The correct approach represents best professional practice because it prioritizes targeted temperature management, TTM, hemodynamic optimization, and respiratory support, all of which are critical for improving neurological outcomes and reducing secondary injury. These interventions are directly supported by current resuscitation guidelines, which emphasize a systematic, evidence-based approach to post-cardiac arrest care. Adherence to these guidelines ensures that patients receive the most effective treatments available, minimizing preventable harm and maximizing the chances of a positive outcome. This aligns with the ethical principle of beneficence, acting in the best interest of the patient. An incorrect approach that focuses solely on immediate discharge without adequate neurological assessment, or TTM, would be a significant regulatory and ethical failure. It would violate guidelines that mandate a period of observation and management to prevent complications and assess neurological status, potentially leading to patient harm and failing the duty of care. Another incorrect approach that neglects hemodynamic monitoring and optimization, such as failing to address hypotension or hypertension, would also be a failure. This neglects critical physiological support necessary for organ perfusion and recovery, contravening established best practices and potentially leading to further organ damage. Finally, an approach that does not consider advanced airway management or ventilation strategies when indicated would be a failure to provide adequate respiratory support, which is crucial for oxygenation and preventing secondary brain injury. This overlooks a fundamental aspect of post-arrest care and could lead to adverse outcomes. The professional reasoning process for similar situations should involve a systematic assessment of the patient's condition, including their neurological status, hemodynamic stability, and respiratory function. This assessment should be guided by current resuscitation guidelines and protocols. Clinicians must then prioritize interventions based on their potential impact on neurological recovery and survival. Continuous monitoring and reassessment are essential, allowing for adjustments to the treatment plan as the patient's condition evolves. Open communication with the patient, if able, and their family, as well as collaboration among the healthcare team, are also vital components of effective post-cardiac arrest care. Question 19. Governance review demonstrates that during a simulated cardiac arrest scenario, a healthcare provider, upon arrival with an automated external defibrillator ED, proceeded to attach the AED pads to the patient's chest over their clothing before attempting to remove the clothing and dry the chest. Which of the following actions, if taken by the provider, would represent the most significant deviation from advanced cardiovascular life support ACL's guidelines regarding AED use? Option A. Delaying the attachment of AED pads to the patient's chest to first administer chest compressions for a prolonged period. Option B. Attaching the AED pads to the patient's chest over their clothing without drying the chest. Option C. Attaching the AED pads to the patient's bare, dry chest and then ensuring all rescuers are clear before the AED analyzes the rhythm. Option D. Attaching the AED pads to the patient's bare, dry chest as per visual prompts, and following the AED's voice prompts for rhythm analysis and shock delivery. The correct answer is D. Attaching the AED pads to the patient's bare, dry chest as per visual prompts, and following the AED's voice prompts for rhythm analysis and shock delivery. Explanation. Scenario analysis. This scenario presents a professional challenge because it requires immediate, life-saving intervention in a critical medical emergency while adhering to established protocols for automated external defibrillator (AED) use. The challenge lies in ensuring that the AED is applied correctly and efficiently, without delay, and in a manner that maximizes the chance of a positive outcome for the patient, all within the context of the Advanced Cardiovascular Life Support (ACLS) guidelines. The presence of bystanders and the need for clear communication add further complexity. Correct approach analysis. The correct approach, which involves immediately attaching the AED pads to the patient's bare chest as per the device's visual prompts, and then following the AED's voice prompts for analysis and shock delivery, represents best professional practice. This aligns directly with ACLS guidelines, which prioritize rapid defibrillation for shockable rhythms. The prompt application of the AED, without unnecessary delay for other interventions that do not directly facilitate defibrillation, is crucial for improving survival rates in cardiac arrest. The visual and auditory prompts are designed for ease of use by trained personnel, ensuring correct pad placement and adherence to the device's operational sequence. Incorrect approaches analysis. One incorrect approach involves delaying AED pad attachment to first administer chest compressions for an extended period before applying the AED. This is a regulatory and ethical failure because it deviates from ACLS protocols that emphasize minimizing interruptions in chest compressions and prioritizing early defibrillation. Prolonged delay in AED application significantly reduces the likelihood of successful defibrillation and patient survival. Another incorrect approach is to attach the AED pads over clothing or to a wet chest without drying it. This represents a failure to adhere to manufacturer instructions and ACLS guidelines, which specify that pads must be applied to a bare, dry chest for optimal electrical conductivity. Inadequate contact due to clothing or moisture can lead to ineffective energy delivery or arcing, potentially harming the patient and rendering the defibrillation attempt unsuccessful. A further incorrect approach involves attempting to analyze the rhythm or deliver a shock without ensuring all rescuers are clear of the patient. This is a critical safety and regulatory failure. ACLS guidelines and AED operating procedures mandate that all personnel maintain a safe distance during rhythm analysis and shock delivery to prevent accidental electrocution. Failure to ensure clearance is a direct violation of safety protocols and could result in injury to rescuers. Professional reasoning. Professionals should approach this situation by prioritizing the immediate and correct application of the AED as per ACLS guidelines. This involves a systematic, protocol-driven response. Assess the patient, call for help, begin CPR, and then immediately apply the AED pads to the bare, dry chest. The decision-making process should be guided by the principle of time is muscle and time is brain, meaning that every second counts in cardiac arrest. Professionals must be proficient in recognizing the need for defibrillation, correctly applying the AED, and following its prompts while ensuring the safety of themselves and others. Regular training and competency assessments in ACLS, including AED use, are essential for maintaining this proficiency. Question 20. Regulatory review indicates that a 65-year-old male is found unresponsive in his chair. Upon assessment, you note that his chest is rising and falling, but his breathing appears shallow and infrequent, with occasional gasping sounds. He does not respond to verbal commands or painful stimuli. What is the most appropriate immediate action to recognize and manage this potential cardiac arrest scenario according to Advanced Cardiovascular Life Support guidelines? Option A. Administer oxygen via a non-rebreather mask and monitor vital signs. Option B. Confirm the presence of a palpable pulse before assessing breathing adequacy. Option C. Immediately begin chest compressions and prepare for defibrillation. Option D. Reassess the patient for a pulse for a full 10 seconds before initiating any interventions. Correct answer is C. Immediately begin chest compressions and prepare for defibrillation. Explanation. Scenario analysis. This scenario presents a common yet critical challenge in emergency care, distinguishing between a patient who is unresponsive due to a reversible cause and one experiencing cardiac arrest. The professional challenge lies in the rapid assessment and accurate recognition of cardiac arrest, as delayed intervention significantly impacts survival rates. The presence of agonal gasps, often mistaken for normal breathing, further complicates the initial assessment, demanding a high level of vigilance and adherence to established protocols. Careful judgment is required to avoid both underrecognition, leading to delayed CPR, and overrecognition, leading to unnecessary interventions. Correct approach analysis. The correct approach aligns with the foundational principles of advanced cardiovascular life support, ACLS, as mandated by the certifying body. ACLS guidelines emphasize a systematic assessment for signs of cardiac arrest. The absence of normal breathing and the presence of absent or abnormal pulses are the primary indicators. Specifically, the recognition of absent normal breathing, or the presence of agonal gasps, which are not normal breathing, coupled with unresponsiveness, is the trigger for initiating CPR and defibrillation. This approach represents best professional practice because it is evidence-based, designed to maximize the chances of successful resuscitation by ensuring prompt and appropriate intervention. Adherence to these protocols is ethically mandated to provide the highest standard of care and fulfill the duty to act. Incorrect approaches analysis. One incorrect approach involves focusing solely on the presence of a pulse without adequately assessing breathing. This fails to recognize that a patient can have a pulse but still be in cardiac arrest if they are not breathing normally. This oversight can lead to a critical delay in initiating CPR and defibrillation, violating the standard of care and potentially causing irreversible harm. Another incorrect approach is to assume the patient is breathing normally simply because chest rise is observed, without confirming the absence of normal respiratory effort. Agonal gasps can cause chest rise, leading to a misinterpretation of the patient's respiratory status. This misjudgment can result in a failure to recognize cardiac arrest and initiate life-saving measures, a direct contravention of the diagnostic criteria for cardiac arrest. A third incorrect approach is to delay intervention based on the hope that the patient will spontaneously recover without any intervention. While spontaneous recovery can occur in some medical emergencies, it is not the expected outcome for cardiac arrest. Waiting for spontaneous recovery in a patient exhibiting signs of cardiac arrest is a failure to act promptly and decisively, which is a significant ethical and professional failing, as it abandons the patient to a predictably fatal outcome. Professional reasoning. Professionals should employ a structured decision-making process based on ACLS algorithms. This involves a rapid primary survey, checking for responsiveness, calling for help, opening the airway, assessing for normal breathing, and checking for a pulse. The critical decision point for recognizing cardiac arrest hinges on the simultaneous presence of unresponsiveness, absence of normal breathing, including agonal gasps, and absent or abnormal central pulses. If these criteria are met, immediate initiation of CPR and preparation for defibrillation are paramount. This systematic approach ensures that all critical signs are evaluated, minimizing the risk of misdiagnosis and ensuring timely, life-saving interventions.